Hello, 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 everyone. Welcome to another edition of What's Up, Doc? Today we are so excited. We have someone I admire so much, and I've been watching from a distance for so long. Dr. Vincent Rowe from UCLA. He's a vascular and endovascular specialist, and he's also head of the department there at UCLA in Southern California. Thank you so much for taking time out of your really busy day of clinic and procedures to join us to answer questions from our network, the Global PAD Association.
Oh, no, thank you for having me. It's wonderful work that you're doing, and I'm just glad to be a part of it.
Thank you so much. You even just had, the opportunity to treat one of our patients, aortobifemoral bypass. This poor patient had been waiting forever to get diagnosed. And because of the delay in diagnosis, it ended up where endovascular or minimally invasive treatments with wires and balloons just wasn't an option. Can you talk about the problem you see with the lack of early diagnosis, some of the cases that you may have experienced, and how maybe you're hoping that this will change?
Well, early diagnosis is important mainly because it gives the patient the chance to do something about the risk factors. If I make excuse me, a diagnosis of someone and I tell them you have some arterial disease, uh, I can tell them what led to it in their particular case. If it's smoking, I can recommend that they stop smoking, and that then it's up to the patient to try to do that. If it's diabetes, I can say, okay, that was the main contributor, and then they can take it upon themselves to try to improve all of the metrics for diabetes. It's same thing. So it's really about getting the patient to understand what they have, because once they have that diagnosis, it's something that they're going to carry with them for a long time. It's hard to say, "Oh, I don't have it anymore. I beat it." No, you're going to have it for a long time, but you're just going to keep it from progressing by controlling your risk factors and doing some of the appropriate things to keep it from getting worse.
I love hearing you talk about mitigating the risk factors because one of the top five questions that we always get from patients in our network is I don't understand why I have PAD. Why do I have PAD? Why are doctors not sitting and actually having the diagnosis and going through? There is a real checklist for PAD, even if it's just general genetics, even if it's just general high cholesterol. You should sit down and have that critical conversation with the patient and go through that checklist so that you can create a long term plan for mitigating those risk factors so that you can stall progression, right?
Yes, well, that's a problem that goes all the way up to Washington in terms of the doctor making that diagnosis early and doing some of the counseling and testing that needs to be done early. Uh, and when I say going all the way up to Washington, let's think about what happens in other areas of our healthcare. Uh, a woman reaches a certain age, we know that she needs a mammogram. We all reach a certain age, we know we need a colonoscopy. And there's other things like that as well. And now we're talking about, for kids, it's vaccines, whether you believe it or not, and so forth. But at each steps in our lives, there's things that we're supposed to have done. And never have we been able to say at certain checkpoint or in certain people with particular risks, they need to get checked for PAD. And so there's been legislation that's been swirling around in Washington for probably a decade. And unfortunately, the person that wrote the bill actually died from having PAD and renal failure. So he actually had the same risk factors. He was a terrible diabetic. He had the same risk factors that he was trying to write a bill to prevent. And he passed away. So we're kind of looking to see who's going to take up the charge, but we haven't been able to get that through. You see commercials for all different kinds of diseases, all different kinds of medications, but you don't see anything for PAD, and so we're somewhat behind. in our patient education. We're somewhat behind in our screening, and we're definitely behind in getting things mandated for the patients that, hey, you reach a certain age and you smoke or you have high blood pressure, you need this test, and your insurance company should pay for it. If that was in place, we would get a lot more diagnoses.
Well, if that was in place, we also wouldn't need nonprofit organizations to put together free clinics to where they actually get that. Where does the responsibility lie? Should it be these 501(c)(3)s going out and creating all of these free testing sites for PAD, or should it just simply be a part of the healthcare system and the standard protocol for patients that are particularly at high risk?
I think it should be part of the healthcare system for particular high-risk patients. If we said you reach the age of, say, 40 or 45 and you're diabetic or you're on an antihypertensive medication or your cholesterol has reached a certain level and all the, you could have a checkbox of metrics, whether it's one or two of these things, and you're not necessarily with the disease fully out of control, but it's just you have early signs of it, then you should be tested. And I'm hoping we can get to that. I don't think we're at a point where just check the whole population at age 50, but that would probably lead to some disruption in how all the money flows, and we know that things are changing with all of that in Washington. But I think the most effective way would be to say if you have either one or two of these risk factors at a certain age, you should be tested.
Okay, we have quite a few patients that are rolling in with lots and lots of questions for you. And so I want to get to those. But first, we have Jay, who's in our live studio audience. She's been taking care of her mom. And she, I believe, sent you an angiogram image of a before picture of her mom's arteries. And so I wanted to give Jay the floor and be able to ask you a question. Go ahead,
Sure.
Jay.
Hi, thanks for answering my question. The question I have is, my mom just went through a major ordeal that she experienced, and one could you maybe shine some light on what could have possibly happened where one surgeon saw no options, but the other surgeon was able to somewhat easily open up all of her vessels?
Well, I think, that's a hard one because what's easy for one surgeon may be difficult for another, depending on where they are in their career, their skill set, what they've seen. And so it's hard to say that. And also, oftentimes, you could be dealing with a number of different specialists that have different viewpoints about things. So there's in the vascular realm, you could have had either a vascular surgeon, interventional cardiologist, or interventional radiologist. And we all try to practice along the same guidelines, but some just are more innovative or have seen things more than others. And then, of course, with the vascular surgeon, they oftentimes have the lens of also utilizing surgery. And so it just really depends. But I would say that I was glad that you were able to find the physician that was able to treat your mom effectively, but I wouldn't hold it on an overarching view that people just aren't, someone was doing something wrong. Maybe they just didn't have the insight or they hadn't had the experience as that other provider.
No, definitely agree. Definitely agree.
And it was in her case, in her mom's case, the physician had performed two failed. They at least tried to perform a couple of bypasses. First went in proximally, then went in distally, and it turns out that the patient didn't have any blood flow above the point where they were trying to um, enter in and place the start of the bypass. And we just can't even understand the potential thinking. But of course, we're not surgeons. But are there any questions that a patient, like Jay's mom could have asked, or an advocate like Jay could have asked the surgeon to make sure that this type of situation doesn't happen?
Yeah, that was kind of unfortunate when I looked at the films. I would say, the main question would be, hey, doctor, do you have enough imaging, or do you have enough information to perform the procedure? And most of the time, or practically all of the time, it should be yes. The only time that may be an issue would be if getting more information using that dye to see where all those blockages are would cause more damage to your kidneys or your loved one's kidneys. Then the doc has to be a little more creative. But most of the time, again, that question, if you ask the physician, the answer should be yes, that they have enough. And if they don't, then just they'll start thinking about it when you ask that question, and they'll probably go ahead and make sure they have it.
And we always tell people before any procedure, I don't care what it is, whether it's an intervention, whether it's surgery, that you should always get a second opinion, get a second set of eyes on it to just either get peace of mind or to determine maybe there is another option, because we've had patients who have been on deck for intervention or surgery, including amputation, and we've been able to put them on a very successful regimented walking program to grow their own natural bypasses and prevent any sort of procedure at all. And the most shocking to me are those patients that are on deck for amputation. And we're able to, within 3 months, with a regimented walking program, and we have our own through the Global PAD Association that's free to physicians and free to patients. It's a structured walking program that allows a little bit more flexibility, but it's at no cost. The patients were able to avoid amputation by growing their own natural bypasses. Blows my mind.
Yeah. Well, even there, when someone says you need an amputation, again, it goes back to what that provider has seen. Um, those of us that have worked in areas where we've seen patients present very late or with extensive damage to their lower extremity, we've probably seen more than some other providers. So even that, saying that you need an amputation can be somewhat subjective because, yeah, there's been a lot of situations where someone else will say it and I may not, or I may say it and someone else may not. So it really just depends on what you've seen as the
And
provider.
again, in Jay's mom's situation with a bypass, and making sure that the vessels were what we call the landing zone for where the blood flow is rerouted back into the vessel through a synthetic graft or through a person's vein, where they use it as a bypass graft. We had a cardiothoracic surgeon that said that he goes in just to make sure that those small vessels below the knee, the landing zone, are adequate enough for the bypass to be able to suffice or to fuel the leg. But we've seen so many of these bypasses go down because the vessels below the knee, where they place the bypass graft to reroute blood flow into, they're just not good. They're diseased. So you're trying to fix, the inflow with the big vessels right up top, but the vessels below are diseased because of, let's say, diabetes or chronic kidney disease. And so the bypass just goes down. It's just not as durable. And I'm curious, are there any questions that a patient can ask before a bypass to make sure that the vessels below that graft are healthy enough to support the additional flow?
Yeah, well, I don't think the patient should have to ask the physician, but the physician should make the patient aware that, hey, there's so much disease down there that where we're going to be landing the bypass that you will probably need a revision. You'll probably need additional therapies, or it may not work. And so I think the responsible physician should make the patient aware of the situation that they're in
Mm-hmm.
terms of what are some of the things that are in their favor for this to work, and what are some of the things that aren't. And the physician should be able to explain both of those pretty well. And again, I do think the patient can ask, do you have all the information that you need for planning this procedure? And I think that's a good one for a patient to ask. But again, then the doctor has to be able to say, well, these are the things that are in your favor, and these are the things that are not.
Yeah, and there's still a lot of doctors that don't treat in an
Yeah,
endovascular way below the knee. And so, of course, they're going to say, well, there's nothing we can do. So that's why we always
right.
say it's worth, before a major procedure, especially, to get a second opinion. But because we're also seeing a lot of damage during endovascular procedures with doctors that don't consider making sure that they're protecting future surgical options. Um, that we also, again, still suggest a second opinion to make sure that you are getting the best information to make the most informed decision for your presentation of disease.
Yeah.
Okay, so we
Okay.
have quite a few questions here as well from Diane. Long questions here.
Great.
Yesterday, I walked considerable amount. It was in a building, so it was hard floors, wearing sandals. Ah, that's a no-no. When she got home, her left leg was aching so bad, and it went into the arch of her foot and to her heel. It got so bad she couldn't even step on her heel. And then she just woke up this morning and it feels like she's cracked her heel, but she didn't. Is that an issue of PAD, or do you think it might be something else, such as wearing the wrong shoes on a not so good surface for walking?
Well, it doesn't sound like PAD. PAD would have been, you would have had a difficult time just walking because the circulation to your muscles would have been inadequate. And so you would have had to have stopped walking because your muscles ached. This, you were able to keep walking, but you woke up or you went to bed with some pain in your foot and woke up with heel pain. It almost sounds that pain, like in the very front part of the heel, sounds a little bit more like plantar fasciitis than PAD of any kind. So, I mean, it sounds more like a foot issue. And from talking to some of my podiatry friends, they said a lot of this plantar fasciitis with very similar pain occurred during and right after COVID because people were at home walking around barefoot and not going to work because we couldn't go out. And they saw a lot more plantar fasciitis later. But that's what it sounds like. I would suggest getting an evaluation of your foot from a podiatrist. Perhaps you need, like Kim McNicholas said, better supportive shoes, arch support, but it doesn't sound like PAD.
Okay, Rosemary. She had an aortobifemoral bypass surgery 2 years ago, and she said she still has good days and bad days, good numbers with her blood pressure, but she just feels unbalanced, tired, fuzzy head. Anything that she should get checked?
Well, I'm glad the aorta by fem went well for you. There's a lot of things that can go wrong, but if you're 2 years out, it sounds like it's working good for your legs, and so congratulations there. I would say one thing to make sure, especially with dizziness and fogginess, I would get your heart checked and make sure that there's no issues with your heart in terms of the rhythm of the beats. Sometimes you could be skipping beats, it could make you lightheaded. And I would also make sure you get your ultrasound of your neck. You had plaque in your aorta and lower pelvis vessels. That's why you got that big bypass, but maybe you still have some plaque in this area in your carotid arteries. So I would make sure to get those checked as well as your heart for any rhythmical issues that could be occurring, especially when you have those kind of crappy days.
And we have Cindy. Cindy wants to know about PAD, the peripheral artery disease, in your arms. Her fingers get cold and she has a sticky feeling. And we know that getting it in your arms is rare. But what happens when you do? How do you know? And what are the treatment options? And how do you know when you actually need one of those treatments?
Yeah, that's a good question. We see it a lot for people with hand complaints. And most of the time, it's not PAD in the arms, but it can occur. And the hard part is it can occur all the way from in the forearms, in the upper arm, around the chest area. So all of that has to be evaluated because those vessels start here and then go out. So we usually recommend at least an ultrasound of some of those great vessels here in the shoulder and neck region to start. And if there's any issue there, then we proceed with something like a CT scan so we can see everything. But it is very rare, but it can occur. It usually tends to go more to the legs, but if you're having that in your hands, especially it tends to affect the left hand more than the right hand. I would definitely think about getting imaging of that whole area to start with
Do you find that
ultrasound.
more in people that have clotting disorders?
It can. There's a few other things that can happen in the upper extremities, but it doesn't have to be a clotting disorder. They can have plaque in the subclavian vessel. They can have plaque, and to name these proximal vessels here in the chest area, there can be plaque there. There can be plaque a little further out in the vessels that are in the shoulder region. So it's not common, but it can occur. And so a workup has to start at least with an ultrasound to evaluate all the way towards just to about to the inner shoulder and see all those vessels.
And we have Marie, who's in our live studio audience, and she said she had her leg and her groin cleared out about 2 months ago, but her legs become swollen. Is this typical?
She had it cleared out with surgery or with stents.
I think hybrid.
Oh, yeah. So, yes, swelling can happen. Swelling after surgery can definitely happen. Anytime we make an incision, we kind of disrupt the normal drainage of the body fluid in the leg. Most patients are able to compensate for it and they heal okay, but some end up with swelling that's temporary. And I'd say maybe a 5 to 10% end up with swelling that kind of persists. If once they check and make sure there's nothing else wrong in the region, um, hopefully they can start having you do some measures to reduce that swelling, which would be wearing a compression garment, try to stay active and walking, make sure it's not related to anything that you're doing with your diet, and hopefully it should reduce in a little while. But definitely it can occur. Nothing wrong happened in the surgery. It can just happen from any incision that we make on the body.
And Tracy wants to know, what are the standard indications for an aortobifemoral bypass? Should a doctor at least try to go in with extra imaging and a wire to see if they can get through? Why do doctors resort to this major bypass right away if they don't know whether it's rock hard calcium or clot?
Yeah, so the indications are mainly where the perfusion to the legs are just inhibited. You have a hard time walking, um, and it's in that area of the pelvis and aorta. Most of the time, nowadays, you're right. We do attempt to open up some of those iliac vessels, the pelvic vessels with balloons and stents. But if the disease is so extensive that it heads up higher, like all the way up above the belly button, in terms of where the disease continues in the aorta, then we're going to most likely recommend a bypass. But by far, most of the time, we do at least try first with the stents and balloons. And why? Mainly because it's less stressful on you, and we find that it works really well. Still, the gold standard that we compare everything to is the aorta bifem bypass, but we're only using that on less patients nowadays, so they have to kind of reach a selective criteria before we do that. And usually, like I said, we go forward with the stents first.
And we talked about the next one a little bit in the beginning, but I'd like to revisit it again because I think you'll have a different take on it, just in the way in which Sarah has worded this question. Before any intervention or surgical procedure, shouldn't a doctor try to know what's clogging the arteries? Is it clot? Is it calcium? What is it? If it's clot, she says she would think that they would want to do additional testing to know where the clot is coming from, because if they do a procedure, she says, "Won't it just clot back up if they don't mitigate that risk factor?" Her doctor said it doesn't even matter because he's going to put her on Eliquis and Plavix no matter what. But she asked, what if she has AFib that's causing the clotting? What if she has an aneurysm in her aorta that's causing the clotting? Isn't this a good opportunity to not just band-aid my problem, but to get to the source and solve the issue so it doesn't wreak any more havoc? I love the way she worded that and how detailed it is.
Yeah, that's true. You do need to know, so she's right. You do need to know exactly what is the cause. And a lot of that will come from talking about what your risk factors are. I had a patient that presented with a blockage in the artery behind the knee, and his other leg was perfect, and all of his vessels above and below were completely clean, no calcium, no plaque. He was a healthy individual. So that was a person that we looked higher up, and it turned out he had something in his heart that was sending down plaque, and he had a big plaque, piece of clot go down and block his artery behind the knee. So he's going to be treated differently than someone that, say, has a long history of smoking and diabetes and high cholesterol, that's going to have plaque all the way through and maybe have issues with buildup of plaque. So you're right. We do need to know exactly what the cause is, and that's important. And oftentimes it may not just come from in the abdomen. It may actually come from way up in the chest or in the heart. And a good search should be performed if we are thinking that it's not due to that standard buildup of plaque that we see. If it's due to a piece of plaque or blood clot traveling down, yeah, we have to look very closely.
That I'm going to skip around here on the questions, but I want to go to Callie because it just is a little bit more to do with that. She wants you to talk about what you actually see when you do surgery or intervention on someone with diabetes. What does the blood actually look like when the A1C is not controlled? I think that is such a good question.
Yeah, that's a good question. So the blood actually looks the same. The big risk with someone whose A1C is out of control is how are they going to heal? You're at a higher risk of having an infection after surgery. You're at a higher risk of that wound not completely healing and locking closed with all of your proteins in your body. So you're at higher risk for that. And what's the biggest difference for someone with long-standing diabetes is mainly that the vessels itself will be much harder. So as opposed to having a vessel that's kind of soft like a straw, now you have a vessel that's almost like a pipe. It can get very hard depending on how their body has been adjusting to having and diabetes. So I would say the main issue with A1C out of control is one, the healing potential, and two, the risk of infection, and three, not how the blood looks, but how the vessel looks. The vessel can be very deranged if you've had a long time being out of control. And we can see that it makes surgery that we do open surgery, it makes surgery with stents and balloons, it makes everything harder.
And Tara wants to know, how should PAD patients cope with the heat of the summer? Any tricks or tips? I would imagine it doesn't just have to do with the PAD, it has to do with a lot of the medications that they're on as well.
Yeah, that's going to be a big component of it, all the medications. But yeah, all these heat waves are coming. I would say one thing, try not to get dehydrated. Um, getting very, very dehydrated, your blood pressure could go low. Maybe that little blockage can turn all the way to a complete occlusion in your legs if you get severely dehydrated. So just try to stay the best hydrated you can within reason, not drinking 18 liters a day, but within reason, try to stay hydrated and try to be active. If you're on that walking regimen that they've given you, my mom used to go to Costco to walk. Just go in and walk around, walk the aisles, the mall, someplace air conditioned, just to try to be able to continue on your regimen. If you can't do any of those, then it may have to either be very early in the morning or late afternoon, late in the evening to try to walk and just try to maintain some type of physical activity. I'd say that would be very important. And the last part, if none of those are feasible, you're in an area that's not very safe to walk, perhaps a very reduced gym membership where you can at least go to that place and have people around you where you feel safe and just do the exercise bike or something like that.
And a question from Anonymous. What supplements do you suggest for your patients with PAD? Any favorites? Because I'm going to tell you, I wish more doctors would talk about supplements with their patients because it is one of the top 5, again, questions that we get. And these patients are using Dr. Google and Amazon to find these supplements
Right,
and
right.
all of the Facebook ads that come their way that have all of these different supplements that clean your arteries. So
Yeah.
it's better if you, as the vascular surgeon, offers some ideas on the best supplements that you would suggest, like CoQ10 even.
Yeah, well, I would say first I have to just act like the standard physician. Aspirin's going to be key. Please don't substitute that. Um, Outside of that, now you want to go with more natural supplements. I would say the best would be because the building up of plaque in your vessels is an inflammatory process. That's why the statins work. If you've heard the term statin drugs, the cholesterol medications, it was kind of interesting. It wasn't necessarily that we want to lower your cholesterol down. It's nice that that happens, but we found out that the other key effect is that it reduces inflammation in your body and in the plaque. So that's what we're really giving it to you for. So even if you have PAD and a normal cholesterol, we'll still put you on a statin for the anti-inflammatory effect. So I say all that to say that there's a lot of agents that will help reduce inflammation in your body, different antioxidants, turmeric, and a lot of other agents. And so look for things that will say, okay, we're going to really help be effective naturally in reducing inflammation in your body. And whatever you can do to do that will be beneficial to you for sure, especially if you're getting close to having PAD. So I'd say those would be the regimens that would be most beneficial.
Absolutely brilliant. I've never heard someone describe that about statins like that before. So that's going to be super helpful. We have a
You
tough
know, there's
question
a
coming.
lot of medications that turned out like that. Rogain that men like me take for hair loss. It's originally was a blood pressure medication, and they were using this on people, and patients would come back and say, I'm growing hair all over the place. And so then they said, oh, let's now market it for that. And then now you have Rogain and other medications were very similar. They just kind of
And
stumbled across the other effect and then marketed it that way.
they're seeing that as well. They just had the STRIDE trial with the semaglutides, the
Yeah,
Ozempics and such that actually end up improving walking distance. And the number one reason
right,
is they realize, well, it's reducing inflammation. And in
right.
reducing inflammation, the patients are able to walk further and faster, but also in reducing the A1C, the blood is no longer thick and syrupy, so it can, get through those smaller collateral vessels as well. So that could also be a reason. But inflammation was the number one thing that was cited as to why these patients with those weight loss drugs and A1C lowering drugs, um, that they would help them walk further. And they said it's inflammation. So just
Reducing the
interesting.
inflammation is really the key, and a lot of it starts with you, how you handle your stress, how you rest, how what you eat, and all of those things can contribute. And so I think that is going to be the key. And if you add a supplement that helps to do that for you, those would be the ones where you'll see the most benefit.
And food is medicine. Look up an anti-inflammatory diet. That's key
Yeah.
as well.
Yeah.
Um, we have a tough one from Melody, and I'm not sure how you can answer this question. It really makes me sad because I see her posting in our network quite a bit. Her dad has cancer and has been marked palliative in the UK. Doctors refused to open his leg arteries to stop his legs from dying while he awaits the cancer to take him. They say it's just not worth it because he's going to die anyway, but they claim the legs are now going to take him before the cancer, so she doesn't understand why they refuse to treat so he can at least die with dignity and die in comfort. She says, do you realize how painful it is for him to have his legs dying, also to watch them deteriorate? She said it's unconscionable. She's curious how doctors in the US handle situations like this, where a patient has cancer and they have CLI, critical limb ischemia, the advanced stage, where their tissue is becoming necrotic. Do you
Yeah.
it, do you treat? Do you not treat? I don't even know if there's any protocol for it.
Yeah. These situations are very complicated for all parties, the patient, the families, and the treating physicians. The first thing that has to happen is an estimate of the cancer. Where are we? Has it spread? Where is it starting from? And how far along are they? Are they showing some signs or responses secondary to the treatments that they're getting, the chemotherapy or radiation? And once you get a good assessment of that, then you're able to talk about, okay, talk to the patient, what's the most important for you? And find out. The patients may say, hey, I just want to be alive, free of this cancer. I don't care what happens to my leg. Or they may be the reverse. I don't care about the cancer, or so to speak. I'm not going to die by losing my leg. I don't want to lose my leg. That's primary for me, because I love to, work in the garden. And if I lose my leg, I won't be able to do that in my last few days. And so I think that's going to be the next step after you assess where they are with the cancer. Then you have to hear what the patient sees, and then it will be usually planning some type of therapy in between the cancer treatments and working around it to try to save the patient's limb. We usually try to keep them out of pain and keep them functional, as the cancer treatments continue or as the cancer advances. At least that's the approach I've used, and I've seen a lot of people that work here around me kind of have the same approach. If you can provide treatment to improve circulation that won't interrupt or interfere with the cancer care, we definitely try to do both at the same time.
Yeah, even if they're marked palliative, it's just a matter of making sure that the patient is comfortable and that they can die in dignity. And so many of our patients say that they would rather die than lose a limb. And
Right,
of course, there are exceptions to that, of course, where we've had to talk the patient into losing the limb so we could save their life as well.
right.
We've had quite a few ECMO patients and patients on, vasopressors that have had to sacrifice their limbs, and we've had to convince them that life is still worth living. They have great family that loves them, and that there are means to help them. But it could work both ways.
Yeah, that's that conversation, honestly, with the patient without a lot of influence from the family, because the patient's decision may be completely contrary to their partner's feelings or family's feelings. And so you got to really hear what that patient wants and how do they see, um, the days that they have remaining. How do they see that happening for them?
And we have, on that note, quite a few questions that we ask every single doctor. And these are
Sure.
these are fun. Everyone loves them. Some of them are geared towards educational opportunities for physicians and clinicians, but others are geared directly towards patients. And we have one that Douglas likes to ask. He is the head of our PAD Warrior Task Force of patients, and he likes to ask every single doctor this question. He wants to hear your best motivational speech for walking as medicine. Pretend I'm the patient and you are trying to convince me to walk, walk, walk.
Oh, well, I would say that this is the treatment that you need. It's free. You can do it whenever you want to, and you can do as much as you want to, but it's really up to you. You are now the one in charge. We're not asking you to take a medication, take an injection. All we're asking you to do is do something that you've been doing since you were 2 years old, is to get up and go walk. And that will help you. And if you're willing to invest that amount of work, which doesn't seem like a lot to me, but if you can do that, I'm willing to invest and take care of you. That's what I usually say.
Good. Do you have any stories of anyone that has walked as medicine that you could share that just makes you smile? Because here is a patient that was struggling, nothing seemed to be working, but you were able to inspire them to walk, walk, walk. And lo and behold, they have kept their legs.
Oh yeah, a lot of them. I have one patient now. She's started walking and walking, and she actually used some other methods of anti-inflammatory, non-traditional methods, like I think the one term is grounding, where people talk about just going barefoot in the sand or going barefoot on the grass, just somewhere where you're barefoot in the earth, to help reduce inflammation. And so she's been doing that, and it's not only helped the circulation to her legs, but it's also helped the circulation to her carotid artery. She had blockage there, and she overall just feels much better. So that's a success story where the walking and using something natural as just standing in grass for 10 minutes has been beneficial to all the plaques that she has in her body, and her A1C has come down.
That is amazing. That
So yeah.
is a story to go viral because that's taking your health into your own hands and is incredible with that outcome. Um, What about a journey to diagnosis? We have our journey to diagnosis series that educates patients on all of the misdiagnosis that are out there, the patients that are going for years without the right diagnosis and doctors climbing the wrong tree and going down the wrong path. Can you share a situation, an actual patient story where you just cringe every time you think, how in the world did the doctor miss this? And how you should not miss this?
Yeah, I'd say the most common is the lower back pain, where patients are diagnosed as having a bad back, but it's actually a circulation problem. And that one, I don't criticize the other providers as much, because the symptoms can be somewhat interrelated. But the most easy thing would be just to check for a pulse. That's an easy part of the exam, and that's the part where it shouldn't be missed. And so I'd say those are the situations where it can oftentimes be misdiagnosed. If a patient has other issues, usually I feel like the docs are suspicious. They may not be screening for it. They may not get all the discussions like we talked about earlier or order the right tests. But usually, if they're suspicious of some type of pain, they'll want PAD ruled out.
It's interesting because we always tell patients who come to us with the question, well, I don't know, is it my back or is it my legs? And a physical therapist taught us a little trick. And I don't know if you would agree or have a different trick to determining that. But if they're at a store and they lean on the shopping cart, does their pain alleviate? If it alleviates by leaning on the shopping cart, then it's probably your back. If it doesn't alleviate, then it may be PAD.
Yeah, well, yeah, if when they're walking now with the cart, if they have to stop walking and they're not leaning over, yeah, then it's PAD. Yeah, we use that one.
I love that. Okay, we have a series called The Pulse, and it's where you share a case in which you learned a valuable lesson that other physicians could learn from. It could have been a success, it could have been a failure. It doesn't matter. But what is a case in which you feel you learned something very valuable from that others could learn from?
Uh, I would say um, there was a case of a young man that had a prior football injury and had damaged the artery behind his back, I mean behind the back of his knee, and had a lot of procedures, had stents and stents and stents, and they all failed. And he said he needed to because he was working as a security guard, and he just didn't really think that he could keep going because of the pain he was having. Um, all I saw for able to treat him was to do a bypass using his vein all the way down about about 6 inches above his ankle. And I said, "Oh boy, that's going to help his foot, but how much will that really help all this guy's big calf muscles?" Because he was still a very muscular guy. And I was like, I don't know if this is going to really help him walk. His foot will be nice and warm and have a lot of circulation, but I don't know what will it do for his calf. And so we did it, and I was really surprised that he's able to walk, he's able to work out, and he's not complaining of anything in his calf muscles. So somehow that bypass must be working, going down and heading back up other vessels or heading up and going, whatever it's doing. I haven't looked at it super closely. I just want to make sure there's no narrowing in it. But somehow it taught me that even though I'm doing something closer to his foot, don't be surprised that it won't help the calf muscles, even those big calf muscles up closer to the knee.
That's a really good lesson. I appreciate that actually, even for our own knowledge. When
Yeah.
patients ask us, I love that because I never even thought about that before. And now we have. So thank you. And we have another series. It's called Spur of the Moment. What were the 6 minutes that mattered in your career? The defining moment, that aha moment. It could be anything. We interviewed, for example, Dr. Mahmoud Razavi, and he shared two different defining moments. One where he realized that, he had a mentor. It was a conversation he had with his mentor, and his mentor said, if the contrast fluid can get through, so can you.
Yeah.
That doesn't mean you can. I mean, just because you can doesn't mean you should. And then the second one was, and I just shared this one today, and it's where you need to have the candid conversation with patients, and you should always manage expectations because he shared a case where a patient with an aortic dissection said, I really want to live. Doctor, am I going to live? And he said, yes. And 6 minutes later, he was gone. And he learned to
Oh,
never
oh.
do that ever again the hard way. So, two defining moments in his career. And with those, what would you want to share as your defining moment, or you might have a few defining moments?
Oh, wow. Yeah, I would say one was just being here as a physician. I didn't think I could because I was afraid of blood. And I was able to get over that in college, just as I was a senior in college. And that's what led me to go into medicine. So I'd say that was a key defining moment in my life. And then,
Was there
um,
a moment though with that where you had this aha, okay, I'm not so afraid of it anymore? There had to have
yeah,
been a
there was,
situation.
because I was working in an emergency room as a volunteer, and I just didn't know which way I was going to go because I was still having those episodes. And then I said, okay, this is it. If it's going to work, whether God would be with me or just fate or what, I needed to know at that moment. And right after that, I wasn't bothered with it. So I knew that I was going to take this turn towards being a physician. And so I'd say that was my biggest defining moment of my life. Um, I'm a person of faith. And so I would say the thing that really helped me at that point was I had to just cry out for intervention from God to lead me that way. But without getting into religion on our talking here, but that was what happened for me in my life. I'd say by far that was the biggest defining moment of my life because I didn't think I could do medicine without that changing for me.
Yeah, you wanted to help people, right? You really wanted to do it, and you were thinking, I really want to do this, but I fear blood. Like, what the heck, God?
Right. Yeah, that
Seriously.
was so that was for me. I've asked people or people have asked me, can you think about a time when you felt that you had some type of spiritual revelation or you were spoken to by whatever means, Buddha, God, Jehovah, that directly gave a message to you. And so that was mine. And so I'd say that was my biggest defining moment of my life.
I love that. And our final question there, and then we have one final question that's coming in from a patient. We have Heinz that has a question here, but we have a series called Personal Best. It's how you excel outside the OR.
Mhm.
And it could be charity work, it could be a sport, it could be simply family, but how that time spent with that hobby, activity, family, charity, whatever it might be, how it helps you, maybe skills or whatever it might be that you have attained through doing that have helped you back in clinic or back in the OR. And I'll give you an example. We have a doctor who coaches football, kids football. And he said in working with the kids, he said he actually learned how to better communicate with his patients because he's so used to talking at a high level, with his textbooks and everything with the medical jargon, that through working with the kids, he's learned to just break it down, not to dumb it down for the patient, but to talk in a normal, plain English way.
Right. Right. Well, I would say for me, um, I participated in team sports a lot. I played a lot of basketball and growing up and in my early years. But then I switched to an individual sport and I switched to cycling. And, I'm not going to do the Tour de France or anything, but I would say that how that sport helped me with what I do is that it says that I have to be prepared if 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 I'm going on a ride and I say I'm going to ride 40 miles or 50 miles, if I haven't prepared, it's on me. I can't blame the bike. I can't blame the weather. I can't blame my clothing. I can't blame my wife or anybody else. It's on me. And so I've learned that I have to be accountable and make myself the best I can possibly for my patients and be there and bring it every day because it's on me to be the best I can for them and no excuses from this, that, this, that, that. It's on me. So I'd say that's what I've used to help me be a better doctor.
I love that. That's powerful. And we have a tough question. We'll end on this, but it's a toughie, I'm going to tell you. From Heinz, he says, since there are more than 15 million cancer survivors and many of them get radiation or chemotherapy, how many survivors have actually come to you and told you that they have PAD or CAD that may have been radiation related? And then the second part of his question is, how many radiation or chemotherapy cancer survivors do you see that said they were never told that they were at risk of CAD or PAD from it?
Yeah, that's an interesting question. There is a risk with radiation, and I guess they're probably not told because it's something that happens usually 1 or 2 decades later, sometimes even three. And so when they're treating you with the radiation, I'm sure if the physician said, "Hey, in 30 years, you may have some blockage in your artery where we're radiating." I mean, if I was the patient, I'd be like, "I could care less about 30 years, doc. Tell me how I'm going to be in 30 days." And so that's probably why it's not always disclosed, or if it is disclosed, it's something that most patients wouldn't pay attention to because it is something that occurs years, decades later. And it's not very common, especially now with newer radiation techniques. They're able to cone in right to the area that they need to. But with some of the older techniques, yeah, it is an issue, but it's not very common. And when we see it, we have treatments that are somewhat different than for a typical plaque patient, but they are successful.
What are some of those options? I would imagine that especially if arteries are damaged, you'd want to bypass them.
Well, yeah, it depends on how the skin is. Let's say they were radiated in the neck and the skin is really hard and it's fibrous and you don't want to make an incision on that skin, you should probably treat that with a balloon or stent. But if the skin is okay and you can get down to that vessel, you may want to cut that vessel out and replace it with a piece of their vein or so forth. So it really depends on the radiation, the area that you have to get through to get to that vessel.
And we're getting so many questions. You're very popular. We even have Nancy that is watching online who says this is a great show. And Natalie wants to know, if you build collateral vessels, will your ABI increase?
It may or may not because it depends on what part of the collaterals you're talking about. The collaterals up in the thigh or up higher, definitely. The ABI should increase, yes. And the collaterals are the other networks that form then when there's a blockage. And that was discovered probably 70, 80 years ago by I think it was Dr. Hunter. He was doing some research on reindeers, and he went into the neck area and clipped off the vessel that was the main one to the antlers. And then he saw that they stopped growing and they weren't going as much. Everything stopped. But then he waited like 6 months later and he saw them start growing again. So then he went back into the neck and to look to see what happened. And he saw these vessels going around the artery that he had clipped off. It just took a while for those collaterals to form. So that's what, can happen. If you have an area, an artery that's blocked and you walk and exercise, your body's going to try to build those collaterals naturally, but then you're going to help build them even more by doing some walking. You're going to help accelerate that process and make those vessels even bigger so that you may not even need some type of intervention. So yes, the ABI will increase.
Thank you so much, Dr. Vincent Rowe, UCLA. We really appreciate you, vascular and endovascular specialist. If you have any questions about PAD, make sure you do go to padhelp.org or call our Leg Saver hotline at 1-833-PAD-LEGS. And don't forget, for great content,